Sometimes I have to do some work. I'm part of admin in my hospital.
Hello.
Hi, Prof.
Hey, good
Hello.
morning or good afternoon for you guys. How are you doing?
Good. Thank you. You're good.
Good. All right. Nice to see you both. It's been a while. Hey, Lillian, how are you?
Hi, I'm fine. Thank you.
Good. All right. So you just started, huh? Like a week or two ago?
Yes, this is my second week.
Second week. Okay, great. All right. How's it going so far?
It's good. I love the place. It's
That's
just a
great.
bit cold.
Yeah, the
It's,
winter settled in
oh, you said it's a
quickly.
bit cold.
Yeah, yeah. It's a bit
Yeah.
cold, but everything else is nice.
Oh, that's great. Oh, that's wonderful. Yeah.
Yeah.
So, well, I'll be there in a few weeks. Um,
Oh, okay, nice.
yeah, I'll
Yeah.
be coming out. I'm going to a week from Sunday. I head to Zimbabwe to help with Erasmus giving a temporal bone course there that week of
Oh,
the 23rd, 24th that week. And then I'll come to Cape Town that weekend. So 2 weeks from Sunday. Yeah, and I'll be here
Okay.
that week. And Lily and you and I will work together, and we'll go to the temporal bone lab, and whoever else is available.
Okay.
Yeah, that'll be
Yeah,
great. Yeah,
it will be
yeah.
great.
What do you get? Yeah, I'm
I'm
sorry.
looking forward to it.
Yeah, it'll be great. Yeah, it'll be great. So, how's everything else going? Divya, how you doing?
I'm good. I'm writing exams in 3 months'
Oh, wow. Yeah, so
time.
you're doing some studying.
Yeah,
Yeah,
lots of studying.
that's great. That's great. How's that coming along? It's good.
Good,
Yeah. Oh,
good.
great. Do you guys have some OR today, or what's going on
No,
today?
No, we just had
No,
a busy clinic.
no.
kind of
I just had,
quiet
yeah,
day.
it was quiet day. Yeah,
Quiet day. Got it.
yeah.
Got it. Okay. Okay. Great. Well, let's give it a
Mhm.
second here, and then we'll do. You may have seen some of these before, David. The cases. We'll do some chronic ear cases to get started. Hey.
Hello,
All right. All right. There she is. Hey, touch name. How are you?
I'm fine. I'm a bit hungover from our Eid celebrations. It's not from alcohol, from sugar. Otherwise, I'm fine.
Yeah. Yeah. Nice. You're home today, huh?
I am. Yeah, I am.
Oh, that's nice. Oh, that's nice. You don't have a full head neck list today, huh?
No, I don't. But it's funny. I've been home for 2 weeks, but every single day I've had to do, administrative work. It just,
Oh, sure.
yeah,
Oh,
and
yeah.
it's been meetings after meetings. But Lillian, I have to tell you, I've been invited to Kenya.
Wow, nice for the
Yeah.
conference. That's
It is for a
exciting.
conference in October. So if I don't come back by the middle of October, I've been eaten by a lion or something.
No, no, no. So
No
I'll
lions
give
in downtown
some.
Nairobi. What's
Yeah.
conference is that?
It's this Medell's got some hearing meeting. I'm telling
Okay.
you, it's like joining the mafia.
Mhm.
You know, once you sign up for that, it's just I
Yeah.
realize there's some things that I can't say no to.
You're in.
And so it's kind of, it kind of, yeah, because they see it as part of the training. It's like, well, you need to come and give a talk, and I just kind of have to nod my head and say, okay, I'll come. It's
Right.
You're going to love it in Kenya.
but
It's
I
not as
look
hot
forward to it. I'm sure it's going to be interesting. I think it's in some safari
Yeah.
thing. I mean, I don't want to go on a safari. I just want to stay in the
That was one of my first trips to Africa was to Kenya.
Oh,
Yeah.
really?
It was through a private organization, Kenya Relief. There's probably obviously Lily, Magori, Kenya.
Oh,
Yeah.
yeah, in
It's
Migori,
like
yeah.
5 or 6 hours west of Nairobi.
Yes.
Yeah, there's a clinic out there in the middle. There's nothing much out there. So I went out there well over a decade ago. Yeah, they have a small clinic out there that they do. Teams take trips out there and help with surgical cases. And yeah, so that was a long time ago.
Yeah.
But
Yeah,
yeah, we
a
did. We
lot
went
has
down to the Masai Mara. We went down to the Kenyan Tanzanian border, and we did a little safari afterward. That was fascinating. It was amazing. Yeah, yeah. So, but
Yeah. Wow.
yeah, yeah. So you probably won't be that rural. My guess is.
Yeah.
Yeah.
Greg, before you start,
Yeah. Sure.
and
Yeah.
obviously there's I wanted the we're doing clinical cases today. Hey,
Yeah, that's right. We'll
Yeah.
do some chronic ear. We'll start and get as far as
Yeah.
we can and finish them up the next week or two.
yeah.
Mhm.
I just finished the exams, our college exams. That was last week. So I think it would be nice to for practice for Divya as well,
Yes, of
to
course.
answer some of the
Absolutely.
questions. It's quite a strenuous exam in that
Mhm.
the um the examiners are now a lot stricter. I don't,
Oh,
it's not that the case is being asked is stricter, but like if there's some things that you don't mention, you get scored lower. But you
mm,
have to particularly, it's little
yeah.
things, but
Mhm.
obviously,
Sure.
so yeah, so I think that would be a good thing for Divya to practice.
Absolutely.
Mm.
No, that sounds great. Yeah, well, we'll get started. Yeah. And then
Yeah,
are we you have some time to meet tomorrow? Touch team. We're gonna chat tomorrow a little bit about just
we do.
I've got everything
Yeah,
squared away with the scheduling. Just wanted to update you on everything for
yeah, that's absolutely fine.
coming out in a couple weeks. Yeah.
Yeah, I know, I
Yeah,
can't believe it. Yeah, it's
I
going
know.
quickly.
I'll be there on the 27th. I'll get there around the 27th, that's Saturday.
Yeah,
So, yeah. Mm-hmm. Yeah.
perfect. Cool.
Yeah. Yeah. Great. Okay. Let's see. Let me share my screen. Okay. So Divi, you may or may not have seen some of these in the past. I mean, we've gone through these, but it's been a while. So can you guys see this? Can you see the screen?
Yes.
Okay, so let's start. So, we're going to start with some chronic ear cases. And, obviously you're going to see a full spectrum of disease in the ear. So it's really important to just recognize things that may be early, mid, late in their disease progression, because certainly that's going to dictate how you're going to manage that. Okay. So you've got a 58-year-old that comes to the clinic, some progressive tinnitus in the ear, some hearing loss, no otalgia, particularly otorrhea. Was referred to your clinic by the outside, maybe primary care doc, because there was a mass in the canal. Maybe was it wax? Not really sure. And so they're sending it to you for evaluation. No associated vertigo, no real other head or neck complaints. Okay. So Divya, we'll start with you then. So without looking at the left, reading this, can you describe what you're seeing? So if you were talking to Lillian on the phone and she was saying, "Oh, what are you seeing?" Well, how can you describe what this looks like?
Okay, so I see a well circumscribed uh, oral mass in the ear canal, very close to the tympanic membrane. It's round, well circumscribed with smooth borders, and yeah. So it's mostly at the bony cartilaginous junction.
Yeah. Can,
Yeah.
can you describe the actual mass itself a little more detail? Is it, can you give me more specific features about it?
Yeah. So it's around 0.5 by 0.5 centimeters in size. And it looks like a fleshy polyp with
Mhm,
some pus. It's like some pus over it.
mhm. Yeah.
And yeah,
Okay. How does the rest of the ear canal look? What do you think?
the rest of the ear canal looks, it's not edematous. There's some erythema more to the medial side, but the lateral 1/3 of the ear canal is
Hmm.
fine, no edema.
Hmm. Yeah. So you kind of have a polypoid mass that, the other thing you might want to comment too is it fills the bulk of the ear canal, right? So you can't, some other things you might want to know would be, where is this thing coming from? So when you manipulate it's friable, right? So friability portends that it has a tendency to bleed. And hey, Brad, good morning. But you don't really know where it's attached. So that's one thing you also want to know would be, so where is this coming from? Is it a canal origin? Is it maybe coming from the drum? Sometimes in situations like this, it's too large to tell, right? You can't really manipulate it too well, right? Okay. So it's friable. You can see there, it's an EAC. The rest of the external canal is patent. No frank purulence, although it does look like there's a little bit right on the mass itself. And obviously you want to know about cranial nerves, right? So facial nerve is normal. And so what if I told you that the tuning fork lateralizes to this ear and that bone conduction is greater than air conduction? What might that tell you?
Conductive hearing loss on the
Okay.
right ear.
Okay. What if it lateralized to this ear and air was greater than bone? What might that tell you? So when you do a tuning fork and you put it on you do the Weber midline and it lateralizes to one ear, what does
Then
that
it
tell
could be
you? What's that?
sensory. It could either be sensory neural hearing loss in the right ear.
So if it lateralizes, so if a tuning fork lateralizes to one ear or another, it doesn't matter in this particular case. What does that tell you before you do the RINA or the RINA test about the possibilities of that ear what could be going on? Does it give you an idea of a couple of possibilities?
Yeah. So if it's if a Weber lateralizes to the better ear, then it's sensory neural hearing loss. But if it's lateralizing to the worst ear, then it's conductive hearing loss.
Yeah, so it could be, right. So it lateralizes to one side. It could be a conductive loss in that ear, right? Or a sensory neural loss in the contralateral ear. Is that correct?
Yeah.
So then you want to do the RINA, right? Which is going to tell you about air conduction versus bone conduction. So in this case, the bone conduction is greater than air conduction. So that gives you an idea that it's probably what?
Conductive hearing loss.
In that ear, right? Correct. Okay. So you want to validate that always with, so is there anything else you want to know about this patient's history before we go on? And I kind of want to know where you want to go from here. So a couple of things is, are there any other things when you see something like this in someone's ear canal? Are there other things you'd want to know about that patient's history that might be relevant to the diagnosis? So is there anything you'd want to know before we move on?
Yes, so is he diabetic? His past medical history, is he diabetic or immunocompromised, HIV or chronic kidney disorder or leukemia or cancer?
Why do you ask that? What if he was? What would you be concerned
Just
about?
in malignant otitis externa, immunocompromised individuals, diabetic with chronic kidney disease.
Yeah. Yep. Absolutely. So you're thinking maybe necrotizing or malignant otitis externa, right?
Yeah.
So no diabetics here. Any other history that you might want to know so if you think about the differential?
Yeah. TB. Does any TB contacts, loss
Certainly
of weight, cough,
yeah,
night sweats,
uh-huh.
and then if he's lost weight, that also is important. That might point me towards neoplastic conditions.
Yeah. What would be the most common maybe malignancy in the ear canal?
Squamous cell carcinoma.
What other things could you have? What other malignancies could you potentially see in the ear canal?
So squamous cell carcinoma, basal cell carcinoma, osteomas, but that's benign. Osteomas. Sometimes the parotid gland, from the parotid gland, seeding, metastatic.
And what might that be? What would those tissue types be, or what would you find on histology? Some of those things.
Carcinoma.
Right, or they can have undifferentiated carcinoma.
Malignant melanomas can also
happen. And then maybe how about pleomorphic adenomas? Those technically aren't cancer, but they can become, right? So there's a tendency. So that's another thing. Yeah. So it's really important to be thinking about your differential, right? So you know, a lot of things, common things are common, but you still want to be thinking about what other things it could be. Exactly. Okay. So what do you want to do now? So you have an idea, maybe a few things this could be. Where do you go from here? What would you like to get?
Yes. So audio.
Okay. So you want to get an audiogram? Okay. Can you walk us through this audiogram?
Yes. So over the right ear, we can see a masked audiogram where we can appreciate a mild to moderate conductive hearing loss with an airborne gap of around 30 decibels
Okay.
and sloping around 30 decibels, sloping down to over the higher frequencies, while in the left ear it's a normal hearing.
Okay.
Hearing.
Lillian, what do you think? Do you agree with your colleague about her?
Oh, sorry, and there's also a Hertz notch at the 2 kilohertz.
Okay. Okay.
Right. Yeah.
All right. Yeah. Lillian, how would you interpret it? What do you think?
So we have an audiogram. We have the left ear has normal hearing. On the right ear, you can see that there is masking, but I would say that the level of hearing is moderate, sloping down to severe hearing loss in the higher frequencies. And yeah, there's an airborne gap of around 30 decibels.
Mm-hmm. Would you call this a sensory neural loss, a conductive loss, a mixed?
It's actually mixed hearing loss. Yeah.
Yeah, it's a mixed hearing loss because the bone is also different.
Right. So yeah, so remember we talk about the severity based on the air conduction, right? So depends on where you are, but usually 20 to 40 will be construed as a mild loss, and then 40 to 70, we usually will say moderate loss. Some will say, moderate 40 to 60 or so, then 60 to 70 is more severe, moderate, or moderate severe. And then 70 to 90 is severe, and then beyond 90 is profound hearing loss, right? And then obviously we have the cutoffs may vary. Some places might use a 20. All right, guys, we're good. Wow, that's great timing. Hang on a minute.
Uh, While you're taking care of that, let me ask one other historical question, and you might have covered this since I was late. I apologize. Was the patient dizzy at all?
No vertigo. No vertigo. Sorry, guys. I'm in the temporal bone lab over here, and I think they're doing construction in the next room. Perfect. So hey, we'll try to power through it. But some places, and again, Brad, I'm not sure what you guys are doing there, and Lillian, what you guys are doing is usually we'll do a cutoff at about 20 dB on the pure tone averages. So technically in the left ear, that's a borderline normal / mild hearing loss. If you go by 20, but some places will go 25. So, but you want to be aware of that. I think there's that little bit of a wiggle room there on those for the what we call normal hearing for pure tones. But for that, we use 20. I use 20. So I would probably say that's borderline mild / normal pan frequency. Okay. And I don't have word descriptions for you here. So this is just pure tones, right? Okay. So does this fit with your tuning fork exam? If you didn't have the audiogram and you did the tuning fork, could you say, okay, I'm going to draw what I think this could look like based on maybe a 512 hertz tuning fork? Could you get an idea without even having had the audiogram? Yeah, right. So some people will say 512. If you have bone greater than air, you're gonna have a 20 to 25 decibel air bone gap, right? Yeah, so that's pretty good. So that's pretty predictive there. Okay, good. Okay, so Divya, so what's next now? So you've confirmed the hearing loss that you saw in the clinic at the bedside with the tuning fork. You got a good clinical exam. You maybe have a differential in your mind now. So what do you want to do for this patient? What do you think? What is your top 3 in your differential right now?
So autosclerosis.
Otosclerosis. Okay. Because of the
tinnitus, hearing loss, the de facto 2 kilohertz, the conductive.
You're a little off the microphone. Can you? I can't quite hear you again. Can you get close to the microphone? Sorry.
Because of from the clinical history, so the tinnitus and hearing loss, it was a female, and well, that's one. Otherwise, it could be a.
Debbie, you're still off the mic. We can't
Yeah,
hear you
can
very
you
well
slide,
at
slide,
all.
maybe slide to your left a little bit. Try that.
Okay, can you hear me now?
That's better. Yeah, that's better. Thanks.
Yeah.
Thanks a lot.
Yeah.
Perfect.
Okay. So because of the history, the tinnitus, the progressive hearing loss, she's a female, and based on the audiogram, that could be one possibility. Another possibility is that of a cholesteatoma,
Mhm. Okay.
or it could be a superior semicircular. But those two would be my differentials.
Okay, so just based on what you see in the canal, and so she's being referred over for a mass in the canal, right? So, so when you look at the mass, that's kind of your primary target, right? We didn't really ask about SSCD symptoms. She didn't really complain of those things so much. That'd be, and then the other thing we'd want to ask is, has she had previous ear surgery? Has she ever had chronic otorrhea? Any previous perforations of the drum? Those types of, has she ever had ear tubes? So those would be a lot of things you'd want to make sure you ask in your history, right? So she tells you no, you look in the ear, you see this big polyp. So this big polyp or mass, your big three, you've already kind of mentioned them. You mentioned a polyp, you mentioned necrotizing otitis externa, you mentioned maybe malignancy, right? Based on how that looks though, what do you want to do with her? What do you think? Do you want to biopsy it? Do you want to treat it? Do you want to image her? Do you want to, where would you go from here based on that history and where she's at? She's not describing a lot of pain. She's not a diabetic. She's not immunocompromised. This has just kind of been growing there. So where do you want to go from here?
I'd take a biopsy from the ear canal.
Okay.
And send it for MCNS and histology.
Okay. So what are you going to do in the meantime? So that could take several days, weeks to get that result back.
Yeah. So I put in quadriderm in her ear and give her orthotopicals, ciprofloxacin and dexamethasone ear drops.
Mm-hmm. Okay. Okay. All right. Okay. So, would you biopsy then, or would you just treat her with some kind of a topical first and then bring her back? Is that an option? Or would you biopsy, treat her, and then wait for the biopsy, or?
I'd biopsy her and treat her.
Okay. Okay. Lillian, what do you think? What would you do?
I think amongst my differentials, I think about an aural polyp, so probably like an infection. And if the pain is acute, I'd think about things like pharynculosis. Even if it's at the junction, maybe it could be a bit further, and there's like a pharynculosis of the external auditory canal. And so I would first want to treat her and give the patient 2 weeks to come back and then review. And perhaps at that point, I'd make a decision as to whether to do imaging or to do imaging or to do a biopsy based on how it reacts to the medication.
Yeah. Tashteem, is your hand up?
My hand is up.
Yeah. I don't know if that was an intentional hand raising.
No, would you mind if I just interrupted there and just made a few comments?
No, please do. No, go
so,
ahead.
The first thing, well, this is for Div. Remember, you've got to put together the clinical picture with that scenario. So, just in time, I realize we're not working towards an exam, but there is an exam that you have to exit at the end, right? So there's a memo in front of that examiner, and what they're looking at is, what is this person think? Are they thinking like an ENT surgeon who's about to exit? So if you put together, so what's got to be on the top of your differential is not what is listed in a textbook, is this in this picture in that audiogram with this clinical scenario, what would be the first diagnosis at the top? Do you understand what I'm saying? And because they're actually looking at the way you're thinking and going according to a memo, and there's some things that you have to mention first. So I wouldn't put, for example, otosclerosis at the top.
Oh, okay. Yeah. Okay.
Yeah, you have to make that knowledge and experience has got to come together, and it's got to be reflected in how you present at the end. And that's why it's important that you do this, because I just feel like without the practice, it just doesn't happen. The other thing is, if you want to score at Greg and Brad, you can correct me if I'm wrong. I mean, when I look at that audio, and the other thing is, what you would actually do in the clinic is you're going to look at that ear under the microscope, aren't you?
Yeah.
Then you have to actually say that in an exam, you see. So you
Oh.
have to say, I would want to examine this under microscope, see if I can see where this is attached to. Is it attached to the canal? Is it arising from the middle ear? And when you look at that audio and that clinical picture, what do you want to, I mean, when I look at that audio, I think, well, it would be very interesting to see where that polyp is arising from. But when I look at the type of audiogram, I would expect that it's probably arising from the middle ear. Because something that's just arising from the canal, Greg and Brad, correct me if I'm wrong here, but you wouldn't kind of see that type of picture. You probably see a bit of a more pan-cochlear type of hearing loss, isn't it? I don't know. I'm just looking at it in terms of the type of, yes. I don't know if that audio is from that patient.
No, it's not. It's not. It's
So, if you said something like that, then you'd get a 7. And then you're kind of going towards, well, clearly this person is thinking critically. It's not just, but at the moment you're listing textbook stuff, but you're not putting together the scenario. And I think this is really crucial. They want to see you thinking like a specialist. So if I look at that audio, obviously I want to have a look under the microscope, see if I can see where it's coming from. But if we're looking at that audio, I'm almost certain it's arising from the middle ear. And that's something that you could say. Okay. Sorry for interrupting.
No, Tashneem, no, thank you. That's really important. And just to echo what Tashneem is saying, she's absolutely right. The reviewer wants to know what your thinking is. So it's almost a thinking out loud process. Now, if they asked you later and they say, well, okay, beyond the polyp, what other syndromes or conditions could present with this kind of finding? And then you could say, sure, well, SSCD, you might have a low frequency conductive loss or mixed loss even. Otosclerosis, but you'd want to get acoustic reflexes, for example, right? But Tashneem's absolutely right. You're here to evaluate the polyp, the mass, right? And you want to kind of think about that in that context. Exactly right. So yeah, so Lillian's correct. So I would so if you think about your differential, so you would, the most common things being common here, right? If it's coming from the drum. And I always tell that with the residents too. The worst thing they can do in my clinic is when I say, so how to look under how was the ear exam? And say, oh, it's fine. They go in there and I see that they've used the handheld otoscope in the clinic. That's like, we're the specialists. You've got to do a thorough comprehensive exam under binocular microscopy if it's available, right? If it's not, of course, that's a different story, but yeah. So, right. So most people wouldn't jump right to this. They wouldn't, if you're thinking about this maybe being a polyp, you probably wouldn't necessarily go right to this, but I bring this up just so we can talk a little bit about the anatomy here. So Divya, just tell us what you're seeing here. Can you describe this to everyone?
So this is the axial CT temporal bone view of the right ear, where we can appreciate there is a 3 centimeter mass completely occluding the middle half of the ear canal, and not going through to the middle ear, so it's confined to the external ear. The middle ear here, we can't appreciate any, on this view, we can't appreciate the ear ossicles. It's well aerated, the middle ear cavity. And we can see that the sinus the sinus tympani is clear from any mass. So it's been, for me, this is the oral polyp is confined to the external ear canal.
So so one thing you want to say, you did well there. So you want to say this is a non-contrasted axial temporal bone scan through an axial view at the level of likely the basal turn of the cochlea near the round window. So you immediately tell them that at what level. They know that you're looking at the level. And then the other things too is you don't have to give a size. You don't know the size, right? So you don't have to try to guess size. You can just say there's a soft tissue density in the medial ear canal that appears to be abutting the tympanic membrane. The middle ear appears to be somewhat compressed, but is still aerated. And you would also want to comment on what's the bone like? What do you see in the rest of the bone? Do you see anything that looks erosive or moth-eaten or destroyed? Those are some of the other things you'd want to comment on.
Mm.
Right?
So
How
there's
does
some bony erosion on the inferior aspect
inferior aspect of what?
of the ear canal.
Is it in, can you tell inferior with an axial view at this level?
Sorry. Posterior aspect of the ear canal.
Why do you say it's eroded? Or why do you say? Where do you think it's eroded?
It's towards near the tympanic membrane.
Yeah, it doesn't look too bad there. I think, yeah, you want to look at the continuity of the canal itself. It looks fairly smooth along the lining of the canal. Yeah, I mean, I would say that's maybe a soft call, but I would say there's no frank bony erosion. The mastoid is underdeveloped, under pneumatized, and not particularly well aerated, right? There's a very proud sigmoid sinus. Now, again, I'm throwing this in just as a little bit of a teaser for you because it's not really, most people in this situation probably wouldn't have gotten a scan right off the bat. If you're thinking about this as being a polyp, you would likely treat it first. So diagnosis likely on this, most common thing, you want to look at it under the microscope, look at where it's pedicled from. This is coming likely from the canal or from the drum. It's likely a polyp. You're going to see a lot of these, right? So aural polyps, it's just a benign tissue rising usually from the EAC surface or from the EAC, or usually most likely from the TM, right? And it's just a manifestation typically of some kind of underlying infectious process or that's been infected, usually from cholesteatoma, right? So you rarely see this in otitis externa, in routine otitis externa, right? You've probably seen malignant otitis externa, right? Where it's more lateral to BC junction. This one looked pretty smooth and more medial adjacent to the drum. So those are the things you want to tell the reviewer right off the bat, right? And say probably an aural polyp. This, I'm concerned. I can't see on the CT scan. I can't see the attic. I can't see the epitympanum, which is more likely that's where it's going to arise from because of the pars flaccida typically getting retracted in. This could be that. I don't know. But you want to talk about the astrobial differential. You've already covered that. Malignant otitis externa, a primary malignancy, or maybe something coming from the parotid. But you're going to palpate the parotid. The rest of your exam will be that. You'll have already looked at that. So as Lillian mentioned, absolutely, right? So you're going to work on trying to do you're going to try to cool off this polyp, right? So you're going to try to treat it with some topical steroid and antibiotic formula if you can. And then you want to see them back within a week to 10 days. If that typically has not started to resolve, nope, she's taking off. If it's not resolving, got to answer page. Yeah, if it doesn't resolve, or then I would biopsy at that point. But most of the time, if it's an inflammatory cap, like it typically is, that's going to recede down a bit, and you're going to be able to see what's underneath there, which is usually some kind of defect, maybe an attic defect or some kind of retraction pocket that has squamous debris trapped in it, right? Yeah. So let's see here. Okay. All right. So let's, Lillian, any questions about that one?
No.
What do you, in Kenya, what would you typically treat that person with? So if somebody came into your clinic, what would you treat them with? What specific agents would you treat them with?
So if they came to my clinic first, if there was debris in the external auditory canal, I'd clean it out.
Mhm.
And after doing the oral toilet, unfortunately, we don't have quadriderm. So we usually just put in some ciprofloxacin with dexamethasone ear drops.
Right.
And I would ask the patient to continue with that for another 2 weeks, 3
Mhm.
times in a day, and give them water precautions as they go home to make sure that water doesn't get into the ear canal.
Okay. Yeah. Great. Excellent. Yeah. And then
Hey,
we
can
see
I
them
just
back.
ask?
Yeah.
Sorry, Greg.
No,
Yeah,
that's
sorry,
okay.
can I
Yeah.
just ask what you guys use back in the States?
Yeah. So we'll use a combination of ciprofloxacin and some kind of steroid. Together,
As a drop.
it's called Ciprodex. So
Oh,
ciprofloxacin
okay.
dexamethasone is a combo. It's extremely expensive, which is silly because if you order the components separately, ciprofloxacin, and they call it Pred Forte, which is like a prednisone drop, you can put those in separately and it's much cheaper. The simple fact that they mixed them together and put them in one bottle and sell it out, that it's crazy expensive. So
Yeah.
usually Ciprodex or the two components of that. And I'll go usually twice per day for about a week to 10 days and see them back. And then reevaluate it and tell them, and then if there's any persistence there, if it hasn't changed, then I definitely biopsy it. I have had some situations where it didn't actually melt away the polyp or didn't alleviate the polyp, and it was still that on biopsy. So it's kind of strange, but that's rare. I think that's rare.
Yeah. So just Divya is now unfortunately not there, but just
Yeah.
the quadriderm that we use
Mhm.
it's got an antifungal, it's got a steroid
Yeah.
in it. But the other
Okay.
thing that I think the residents often forget is that it's got gentamicin in it, which is
Oh,
ototoxic.
yes.
And it's not really licensed to use in the ear. It's something the dermatologists use. So you can use it for like an otitis externa where the tympanic membrane is intact.
Yeah.
But you definitely can't use it if there's a perforation. It is ototoxic.
Yeah.
And I
And
think this is something
toxic.
that often forget. So I use it for otitis externa. It works incredibly well, but you never want to use it if there's a perforation. So
Yeah.
it's just something for Lillian to be aware of, because you come across quadriderm in our clinic and everybody puts in quadriderm like it's like the next thing, and but it's just you can't use it where there's a perforation.
Wow. And touch name, it's called quadriderm.
It's called quadriderm, yeah.
Okay.
So we use.
Oh, I'm sorry. Go ahead.
No, sorry, what you were saying?
Oh, I was going to ask, do the primary care docs use it?
No,
Okay, good. Because if they don't know that, they could
no,
be, yeah,
no,
putting
they
in
don't. Yeah.
perforated drums and then,
Yeah, this is something that's it's the dermatologists use it, they prescribe it. It's very expensive.
Okay.
And
Yeah.
they did away with there was another drop that we used for otitis externa that they stopped. So the only thing we have for otitis externa at the moment, other than the ciprofloxacin, which is expensive, is acetic acid drops.
Yeah.
For 1% acetic acid.
Yeah, sure. Yeah.
Yeah, but it's just something for Lillian to be aware of. The quadriderm
Yeah.
is ototoxic, so I would never use it when someone's got a perforation. It's fine for otitis externa where there's the tympanic membrane is intact, but otherwise not. Yeah.
Yeah.
Okay.
Yeah. Thank you, Tashneem. Yeah. So, okay. So let's go back to this now. Okay. All right. So let's do the second case here. So you got a 74-year-old with progressive hearing loss in the right ear. So obviously really important to note the timing of hearing loss, right? Obviously sudden versus progressive can portend different etiologies, right? And treatment management. There's been no concurrent pain or drainage from the ear. Okay, just progressive loss. Apparently he's had a previous ear tube placed in the past for some hearing loss, uncertain as to what's actually was going on at that time, but didn't help their parent conductive hearing loss in the past. And then there's no associated vertigo, there's no tinnitus. Okay. So here's your exam. So without looking at the wording, can you describe to us what you're seeing here?
So this is an otoscopic image of the right, yes, of the left ear actually. This is an otoscopic image of the left ear. It is showing anteriorly, the eardrum looks normal. And posteriorly, we have a retraction, an area of retraction with what looks like a dimeric membrane or a healed previous perforation, probably the site where the PE tube was. But there's also obvious, there's a region of atelectasis on the posterior side. The
Okay.
ear canal looks normal, and the ossicles are also quite prominent.
Okay. So you mentioned this is the left ear. Why do you think it's the left ear?
I think it's the left ear because actually it's the right. Just 1 minute, let me orient myself.
It's okay. No, think about it. Think about it.
Yeah, I think it's the right ear. And why I think it's the right ear is because of the light reflex, the
Okay.
direction of the light reflex.
Okay. Is there any, let's say you didn't have the light reflex. Is there any other anatomy that you're seeing that would tip you off about the side of the ear that you're looking at?
Yes, when you look at the orientation of the malleus, the landmarks in terms of the neck, area of the neck, where it connects to the handle of the malleus.
Okay. Is there anything else beyond that that tells you more orientation? Are there any other anatomic features that you can see that would tell you where you are?
Okay, there is the location of the malleus. There is the light reflex, and the other thing to see is the landmark that is supposed to show the incudostapedial joint, though it is not very clear through this lemeric membrane. But when you see the incudostapedial joint, it is usually more posterior as compared to anterior. So those are the main things that tell you anterior from posterior.
That's right. Exactly right. You got it right. Yeah. So you're seeing elements of the incudostapedial joint there. Exactly right. Okay. Yeah. So you're right. So you're seeing, so what parts of the tympanic membrane is there that seems abnormal? You know, when we talk about quadrants of the drum, right? Can you be specific on which quadrants of the drum might be impacted?
So mainly the impaction is on the posterior superior and posterior inferior quadrants of the eardrum.
Right. Exactly right. And is there anything else about this ear? Is there any other areas that you could comment on that we just need to know about that could have clinical significance?
So another area that is the area of the pars flaccida, which is above the handle of the malleus. So, and in this ear, it looks like there's a bit of some retraction, though it's not very, very clear. And
yeah, that's right. That's right. But it's clean, right? There's no.
Yes, it's very clean. It's actually shiny. Yeah, it is shiny from here.
Exactly right. Okay, good. Yeah. So how, if you were describing this to Tashim on the phone, what would you say in a nutshell then looks like? Would you say this is how would you describe it? Just so if you just summarize your findings then.
So I would say that this is a patient with who on otoscopic examination, the right ear has a normal external auditory canal with an intact tympanic membrane that has a retraction in the posterior inferior and posterior superior and posterior inferior area with what looks like a healed, which looks healed or a dimeric membrane and an area of the pars flaccida is quite clear with no squamous debris. The rest of the eardrum is normal.
Okay.
That is the anterior.
Okay.
Sorry.
Yeah. Yeah. So is there what other important thing might you want to do before you finish your exam on this patient? Is there anything that would be really important to do while you're under microscope and you're looking at the ear?
So I would ask the patient to do a Valsalva maneuver to try and see whether they can be able to push the eardrum. So of interest would be to ask the patient to do that so that you can examine the movement of the retraction. Or if I have a Siegel speculum, then probably push some air and see whether it's going to move the eardrum.
Okay. And how would you, so what if you under negative pressure, you're not able to bring the retraction off of the underlying contents? How would you describe that?
So I know that we are able, there's a way we're supposed to grade retractions according to the TOS and SEDS classification, but I need to refresh my knowledge on that. I haven't looked at
Well, that's okay. Just in general terms, if the drum is not able to be pulled off under negative pressure off of the underlying structures, like what you see here, how might you describe that versus one where the drum is very thin and is actually able to be pulled off? Is there a difference in how you describe that?
Yes, so it would be like an atelectatic ear.
Versus which one's atelectatic? The one you pull off or the one you can't pull off?
The one you can't pull off is atelectatic. The one that you can't pull off is would be a retraction with that is mobile.
Okay. Okay. Yeah. So we'll chat about that in a little bit. So yeah. So here under pneumatic otoscopy, you're absolutely the right, the anterior superior and the anterior inferior portions of the drum are mobile, but the posterior aspects are not. So it's very stuck down to the underlying structure near the incus and the stapes there. What do you call that when you've got it the drum shrunk wrapped over those structures? Have you ever heard of a term? What might that be called? Have you ever heard of a stapediopexy, incudostapediopexy? Does that ever ring a bell? Where the drum is kind of shrunk wrapped over those structures? You never heard that term?
No, honestly, I haven't.
Okay.
But I'm going to look it up and read.
Have you ever heard of that? Incudostapediopexy? Have you heard of that? Okay. Yeah. So something to remind yourself about. So that's a good descriptive of that. Okay. So the rest of your exam, it seems normal. There's no fluid in the ear. These are all things you'd want to tell a reviewer, right? So I don't see a perforation, active perforation. I don't see any evidence of polyps, middle ear fluid or infection. The attic retraction appears clean. I don't see, there might be some early bony defect near the scutum, but everything else looks fairly clean. It's not infected currently. So you do a tuning fork and it lateralizes to the right ear, but then you have air greater than bone conduction. Okay. So what do you want to do next?
So with this patient, the next thing you want to do is you want to do an audiogram. And this is because when you have lateralization of the ear to that side, with the ear more than bone, you're thinking, yeah.
Okay. So can you talk us through this audio?
So this is so in the audiogram, we have both the left and the right ears. The left ear has normal hearing, but has a notch, a boiler's notch. It has a notch at 4 kilohertz. The right ear has a mild hearing loss, which is more of a conductive hearing loss with an earbone gap of around 20 decibels. And this is a masked, yes, on the right ear is a masked ear, yeah, masked bone.
Okay.
Yeah.
So on the left ear, yeah, so you described that as, so what do you think is going on the left ear if we leave the right ear for a minute? What might
So
that
probably,
audiogram be suggestive of?
so probably on the left ear, when you have the Boyler's notch or a notch at 4 kilohertz, you want to think about noise, early signs of noise-induced hearing loss, but it's supposed to be bilateral. But given that we have a conductive pathology, and there's also a dip on the other side, so probably yes, noise-induced hearing loss.
That's
Yeah.
right. So you might describe that as normal sloping to a moderate notch loss at 4,000 hertz, rising to normal. Something like that, you know, indicative of hearing, of noise-induced hearing loss. Yeah. And then the right ear, yeah. So it's kind of a mild to moderate mixed loss, because technically that low frequency, you know, that one frequency at 250 hertz, you know, right. But that's fitting with your tuning fork, correct? Right?
Yes, it is.
Yeah, exactly right. So it's always good to be able to do, I mean, tuning fork testing is great, but sometimes patients, it depends on how you do the test, that can be very subjective. So always want to validate that with an audio whenever you can. Okay, so what do you want to do with that patient there? You've got this change in the drum. There's no evidence of infection. You've determined that you can't pull the drum off of the underlying structures that it's already adhered to. What do you do now for this patient?
So this is a patient that you want to have take to cater for a middle ear evaluation or middle ear examination. And the point of the middle ear examination is, one, you will do a myringoplasty. So you want to remove the eardrum and replace it. But at the same time, you also want to confirm if there's any issue with the ossicles, which I doubt there is because of the audiogram. So you want to do a myringoplasty for this patient.
Okay.
Yeah.
So if their only complaint is a little bit of hearing loss, so how would you counsel that patient about the risks of that surgery? What if you take them to the OR to do that? So first of all, is it necessary surgery? Is there something you see on the exam that says, oh boy, we got to take you to the OR and do a middle ear exploration? You don't see cholesteatoma, you don't see polyp, there's no infection. So I guess the question is it necessary to go to the OR? And if you do, what are the risks of doing that surgery versus the benefits?
So for this patient, if the problem of the patient is to improve the hearing, and given his age, I think hearing aids would be a better bet for him than going for surgery. And this is because the surgery one stands a greater risk of the hearing being worse as compared to improving the hearing when you do the surgery. There's a higher risk. So for him, the priority would not be to take him for surgery, but to give him hearing aids. Unless he really does not want to use the hearing aids, then you can try to do the surgery. But again, the surgery is likely to make the hearing worse compared to what it is right now.
Okay. And so then what other risks are there with trying to remove a drum that's stuck down to other underlying structures in the middle or the inner ear, over the inner ear?
One of the biggest risks is subluxing the ossicles.
Okay.
Because the eardrum most of the time is attached to the ossicles. Another thing is that when you have an atelectactic ear, is probably because it points to the ventilation of that middle ear cavity. And so sometimes, especially if the patient has eustachian tube issues or has some chronic granulation tissue, the disease might not really be cured from replacing with a graft. And so you just stand a greater risk of graft failure compared to a normal ear.
What would happen if you didn't get all the old drum out and you grafted over the top of it? What are you creating? What could you potentially create?
You're going to have an iatrogenic cholesteatoma in that
Right.
ear. So
Right.
yeah.
Right. Yeah, exactly. So, so a couple of things. So one, we would normally get imaging on this. I'm just putting this in there just for us to quickly talk about this. So Lillian, tell me what you're looking at right here.
So I'm looking at coronal cuts of CT scan of the temporal bone. This is, and in this cut, we are able to, this is done at the level of the ossicles. So we are able to appreciate our external auditory canal, which is normal and intact. We're also able to see the atelectatic eardrum with it being adhered to the stapes and the promontory of the cochlea. In terms of the attic is quite clear. It's well aerated, and the head, the ossicles are visible at the level of the attic.
Which
We also
optical, which specific one are you seeing right there with the small arrow?
So the one we can see is the head of the first. Yeah, we can see the malleus. The malleus, the head of the malleus is visible, and also we are able to appreciate a scutum that is quite preserved. It is not eroded, and yes, the inner ear looks normal too.
Okay. What's the area between the malleus and the scutum called?
It is called between the malleus and the scutum.
The head of the malleus and the scutum, there's a little black space right there, air.
Yes.
What do you call that? What do you call that space?
Yeah, the Prozac space.
Prozac space. Yeah, it looks clear,
Prozac
right?
space,
And the epitympanoid looks
yes.
clear, right? And then you're at the level of the internal auditory canal, as you mentioned, and the oval window there. What is that in the medial, excuse me, in the lateral aspect of the internal auditory canal? What is that white signal there that kind of splits the IAC there? What is that called?
The white signal that splits the internal auditory canal.
Yeah,
That's
on its media, on the lateral aspect of the IAC, right
that's
there.
the Bill's bar.
Is that is
I
it Bill's
think I
bar or
Falciform.
the oh, sorry, that's the falciform crest. Yes, the
yeah,
Bill's bar
right, or the
it's
transverse
falciform.
crest, right? It divides the superior compartment from the inferior compartment of the IAC.
Yes.
Yeah, exactly. Yeah, okay, good. Well, I have to get running here, but I want to wrap this case up. So here, I think the important distinction here, you're close. So remember, so chronic otitis media is it's a descriptive to describe any permanent change in the tympanic membrane that's beyond 3 months. Okay, so remember, chronic otitis media versus acute otitis media. You guys have seen acute otitis media. That's usually, purulence behind the drum, plus or minus perforation, but it's acute. It's less than 3 months. So any permanent change of the drum over 3 months, that could be a perforation, that could be a tympanosclerosis, laryngosclerosis, a retraction pocket, any kind of physical change of the drum that's beyond 3 months is construed as chronic otitis media. The key here is to, as we mentioned, is to determine if you have a retraction like what you saw in this picture, is pneumatic otoscopy. If the drum is able to be pulled off of that, if those two quadrants are able to be pulled off of those underlying structures, that would be called chronic atelectatic otitis media. Now, assuming there's no cholesteatoma or anything like that. Because when you have other things in there like cholesteatoma or pus, then you start adding these descriptives. So it could be chronic atelectatic otitis media, chronic suppurative atelectatic otitis media with cholesteatoma. So you see how it can get really descriptive. If you can't pull the drum off of it and it's stuck down like a laryngostapediopexy, or it's adhered to the underlying structures, that's called chronic adhesive otitis media, adhesive. So that's really that's a really important distinction, because now that means the medial aspects or the mucosal portions of that part of the drum, which is in that case the pars tensa, it has been retracted for so long, usually from eustachian tube issues, that it's now adhered to the underlying structures. So putting a tube in that ear, so do you think putting an ear tube in that ear is going to help that posterior, inferior, and posterior superior quadrant? No, not at all, right?
No.
Now, if it's atelectatic, it might, maybe, but it's not. This is adhesive. So an ear tube, so when you're counseling patients, you can say, well, this is adhesive. Putting a tube in here is not going to do you any good at all. We could repair the drum, as you mentioned, Lillian, but that's a very difficult thing to repair. That right there is a pretty safe ear. In the 75-year-old, that's a safe ear. That ear, if you see them back and they do vinegar water rinses and you keep the debris clean, that actually is pretty safe. You can actually quickly turn that safe ear into an unsafe ear by honestly trying to remove all of that extra drum from around the stapes and the incus remnant, and you put cartilage over that, probably is what you'd have to do. Because as you said, you haven't really fixed the underlying etiology, which is probably a eustachian tube. But you risk a couple of things. You risk increasing the conductive loss, but more importantly, you risk creating an iatrogenic cholesteatoma, which is really challenging. So sometimes the best answer is not to operate at all. And as you mentioned, putting a hearing aid, if it's available, is your best thing, because you can really do some damage here. So I rarely graft these unless it's really a patient's kind of driving that, or if we have a real opportunity to improve hearing. But many times these situations under chronic adhesive otitis, you can just amplify them and watch them because they're safe ears. Does that make sense? So
Yes,
the big
it does.
distinction here, the really most important thing, and a reviewer is going to want to hear this, is that you did pneumatic otoscopy and you want to ascertain the condition or the state of that retraction pocket. Is it mobile or not? Can you pull that off or not? Because if you can, you might be able to salvage the ear with a tube. If you can't, putting a tube in is definitely not, you definitely would not do that. Okay. All right, guys. Well, I have to run. I've got to get to clinic here shortly, but it's good. So we have several more of these cases to do, so we'll continue next Friday. But Tashneem, do you have any comments about that?
Hi, Greg. No, I think that was excellent. I mean, I think that's really good review and exam practice. And thanks very much for preparing those cases. I hope everyone has a good weekend.
Yeah, so we have a few more of those. So review some chronic ear things for next. We're going to continue with the chronic ear cases. We'll go to other stuff down the line, but we'll stay with chronic ear for now. And then
yeah.
And then Tashneem, I'll see you tomorrow.
Tomorrow's usual time.
Yeah, that sounds good.
Yeah, perfect.
Yeah, perfect.
Thanks,
Sounds
Greg.
Good.
Thanks. Bye-bye.
Bye, ladies. Thanks a lot. Good to see you, Lily. Good to see you,
Have a good
Divya.
weekend.
Have a good one. See you soon. Okay, bye.
Bye.